Hello, everyone. Welcome to the Preemie Chats. Preemie Chat is our weekly educational sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I am a Preemie mom and executive director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led charitable organization that helps families in and after their NICU stay through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, please check our website, canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching live today, please bring your voice to this table. Leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching from. And today's topic is very preterm infants. Do we really need to intubate? Babies born prematurely needs help to breathe, oxygenate, and make gas exchange after birth. The successful use of continuous positive airway pressure, as known as CPAP, in babies with respiratory distress syndrome was first reported in 1971. Over the next decades, there were differences on the type of CPAP used in hospitals, application in the delivery room, indications for initiation, definitions of failure, routine daily care, and weaning strategies. All this might partially explain why rates of intubation and severe lung disease remains a challenge, especially in babies born weighing less than 1,250 grams. In this presentation, Dr. Sant'Anna will review the literature on non-invasive respiratory support in very preterm infants and the use of a comprehensive protocol for the initiation, maintenance, and discontinuation of bubble CPAP in the McGill University Health Centre. The objective is to demonstrate the association between this initiative and clinical outcomes. And I have here joining us live from Montreal, Dr. Guilherme Sant'Anna, who is a neonatologist at the Neonatal Intensive Care Unit of the Montreal Children's Hospital, professor of pediatrics in the Faculty of Medicine and Health Science Center and Health Science at the McGill University, and a senior clinician scientist at the Research Institute of the McGill University Health Center. Dr. Sant'Anna, thank you so much for joining us here today. It is our last live of 2024, and I think we couldn't wrap up with a better person and topic to share what is happening in this entire world of intubation versus CPAP. So, and for all of you watching us live, please do send your questions and your comments, and Dr. Sant'Anna will address them after his presentation. So the floor is yours.
Thank you, Fabiana. It's a pleasure to talk at the Canadian Premature Babies Foundation. It's an incredible initiative that was led by many of you, and I fully support that. And so you can count on me anytime you need. So very premature babies, do we really need to intubate? And this is kind of a subject of research for many, many years now. I have no financial relationship to disclose. I have no conflict of interest to resolve. Any equipment or device I'll be showing here, I have no link, no relationship with any of these companies. I have to disclose that a lot of the information here I've learned with Dr. Wong that you can see on the pictures here. When he was traveling in Brazil with me, he's a master on avoiding intubation and the use of non-invasive support for premature babies. As Fabiana mentioned, in 1971, Gregory, who was an anesthesiologist, was the first published the first report in the New England Journal of Medicine of babies with respiratory distress, premature babies, successfully treated without mechanical ventilation. In the late 60s, most of these babies survived with intubation and mechanical ventilation, but survival rates were low, around 40 to 50%. And as you can see here on Gregory publication, 16 out of 20 babies with respiratory distress treated with CPAP, which is continuous positive airway pressure, survived. That's an 80% survival. And in 2 of them, they survived without intubation. Interesting is that 1 year before in Toronto, Paul Swire and Maria de Livoria also used non-invasive ventilation with a facial mask and did a randomized control trial with 9 of the 12 survivors never got intubated, were ventilated non-invasively. It was a proof of concept that you can treat very premature babies without intubation. In 1976, Dr. Wong at Columbia first described a device that you can see in the picture here in an 860-gram baby, that they'll be using that device in New York for almost a year and a half, and more than 40 very premature babies survived. And a few years later, they published in an American conference, they presented their center, the center number 3, with a pretty good survival rate and very low incidence of lung disease, or at that time called chronic lung disease. Now we know it's as bronchopulmonary dysplasia. And this center number 3, which was the center where Dr. Wong worked, had the lowest incidence of BPG compared to the other centers. The major difference is that this center was avoiding intubation as much as possible. I thought it was interesting that when I was in Rio de Janeiro as a young neonatologist, we did a little study about endotracheal intubation in the delivery room. Should it be a routine procedure? And at that time, and that's almost 30 years ago, we said, we noticed that in babies around 30 weeks, almost 1/4 never needed to be intubated, suggesting that birth weight and gestational age alone should not guide the decision to intubate babies in the delivery room. A number of randomized control trials have been published between 2000 and 2012. And these trials were trying to answer this question. So for babies born very immature, should they be intubated immediately after birth? So they randomized babies to either CPAP, which is a non-invasive mode of ventilation, compared to intubation and surfactant. And if you put results of the 4 trials together, which was done by Wally Carlo in 2012, you will see that the babies that were initiated on CPAP, which means not intubated, they had a lower rate of death and lung disease. They have a significant lower duration of mechanical ventilation. And for those born between 24 and 25, have a significant lower rate of mortality. So in other words, the extreme preterm babies survived more, and everybody else had less death or BPG and less mechanical ventilation if they were initiated on CPAP compared to intubation. So do we really need to intubate? The answer is most of the time not, except for the very, very immature babies that I'll be showing you that those babies, they had a lower mortality despite they initiated on CPAP, and 83% at some point in the NICU had to be intubated. So even if they will go on into intubation, the initiation with a non-invasive or non-intubation seem to be advantageous. In our center, and I'll show a little bit more the McGill experience, on years 5 and 6 of the new protocol that we're going to go over with you in the next slides, for babies less than 26 weeks, 81% at some point need to be intubated in the NICU. If you flip the coin, it means that 19%, almost 20, never got intubated. So, and this is very important because it's 1 in 5 of those babies that don't need to be intubated. If you adopt a practice to intubate everybody just because they are less than 26 weeks, for every 10 babies, 2 you'll be intubated for no reason. And we know that the major trigger of lung disease and complications is mechanical ventilation. The problem in the trials that I presented to you is that a large number of babies initiated on CPAP fail CPAP therapy, 47%. And compared with infants never intubated, those that failed have higher risks of complications. So a number of non-invasive respiratory support therapies and interventions had been developed, studied, and some implemented over the last 15 years in neonatology. And I separated them here into the ones involving surfactant administration, the ones involving non-invasive respiratory support, and the ones involving some sort of cannula of flow. So there are 14 here. So for surfactant, some people use intubation, surfactant, extubation, or INSURE, or minimally invasive surfactant therapy, or less invasive surfactant administration, or surfactant administration using laryngeal mask, or aerolized surfactant. And all of them have been studied, and there are some ongoing studies in some of them. Also, some places have been using the RAM cannula, which is it's a low flow, high flow nasal cannula, or a high flow nasal cannula therapy, or low flow nasal cannula, usually less than 2 liters per minute. For non-invasive respiratory support, you have a variety of possibilities, from biphasic CPAP to non-synchronized non-invasive ventilation, synchronized non-invasive ventilation, or synchronized with proportionality, which is NIV-NAVA, or even nasal high-frequency oscillatory ventilation. And in our case, we use the bubble CPAP that's not showing here. So let's see some of them, of these therapies. Can they prevent babies to be intubated? A while ago, I know Brett Manley wrote an editorial in Archives, it's almost 10 years ago, on nasal high flow going viral. So you can see here what is a nasal high flow. It's a nasal cannula that are very small, thin. It's easy to use. It's well tolerated by infants. Decreases nasal trauma, and nurses and parents like it. Nasal high flow nasal cannula have been suggested as an alternative form of respiratory support in preterm infants with apnea, respiratory distress, after extubation, or even babies with established bronchopulmonary dysplasia. So the first two could prevent an intubation to happen, and the number 3 could prevent a reintubation to happen. So there are specific recommendations for the use of high flow nasal cannula. The cannula size has to be quite small in the diameter, because you need to have a lot of leak for the air to escape. You should not use flow rates outside of the manufacturer's recommendations. And if your units can adopt it, you should have a clear guideline for initiation, weaning, and discontinuation of the therapy. Some interesting trials have been done in Australia about the use of high flow nasal cannula. The Hyperspace trial, the Hipster trial, and the Hunter trial. And I will briefly show the results of those trials. So the Hipster trial, which was done as a primary mode of therapy to prevent intubation, showed that treatment failure within 72 hours was the double with the high flow compared to CPAP. And the conclusion was that high flow was worse than CPAP to prevent intubation in infants with respiratory distress. The Hunter trial was a similar trial done in non-tertiary special care nurseries, so bigger babies, babies with almost 37 weeks and 2.9 kilos. And again, treatment failure was the double in the high flow nasal cannula group compared to CPAP. In other words, high flow was worse than CPAP therapy. So what about this therapy for extreme preterm infants? So we did a prospective randomized crossover study where we look at the extreme preterm infants undergoing the first extubation. So what happened if we extubate them to high flow nasal cannula compared to CPAP? So we put them on both therapies for 45 minutes, and we did some measurements of breathing, which is rib cage and abdominal movements, and vital signs such as electrocardiogram, oxygen saturation, and O2 needs, oxygen needs. And we analyzed these respiratory signals using an automated biomedical engineering methodology. As you can see, while the babies were on high flow nasal cannula therapy, they had longer respiratory pauses and higher FiO2 needs compared to while they were on CPAP. So this is the same baby exposed to two different modes, and during the stay on high flow nasal cannula, immediately after extubation, they did clearly worse. So in conclusion, high flow nasal cannula therapy to prevent intubation as a non-invasive respiratory support has been associated by many studies with a higher risk of death or BPD, increased respiratory morbidities, delayed on oral feeding, and prolonged hospitalization, and higher failure rates to prevent intubation and mechanical ventilation. Also, a cost-effective analysis was done in one of the Australian trials and showed that the cost records of 435 infants. And basically, CPAP was cost-effective compared to high flow, with a final recommendation that neonatal units choosing to use only one device should apply CPAP as a primary respiratory support. BiPAP is another form of non-invasive support that has been tried to avoid intubation. And here's a comparison of bilevel CPAP with ventilator-delivered CPAP, a subgroup, a secondary analysis of a large Canadian randomized control trial. So this system works by delivering two pressures, a high and a low pressure, and this is cycled. So the machine moves between one CPAP level to the next level and then back. And what the study showed is there's a higher mortality rate in the first 36 hours in the group that has been exposed to this BiPAP therapy. So there is no good recommendation and good reason to use BiPAP to prevent intubation and mechanical ventilation in preterm infants. Those were babies less than a kilo and less than 30 weeks during the study. Non-invasive ventilation or non-invasive intermittent positive pressure ventilation has also been used to prevent intubation or prevent re-intubation. And basically, there are many challenges with NIPPV, such as the ventilator is not synchronized with the baby breathing. There are many leaks when you are delivering a high pressure. And there's the upper airway between the nose, where the pressure is relieved, the upper airway, and then the lungs. And this could be a problem in the effectiveness of non-invasive ventilation. Some Cochrane reviews, many studies have been done evaluating NIPPV in the first 6 hours after birth. And the Cochrane review says that NIPPV likely reduce the risk of respiratory failure and the need for mechanical ventilation in babies that are more than equal 28 weeks. It may also decrease the rate of BPD slightly. However, most trials enroll infants with mean gestational age around 30 weeks. As such, the results of this review do not apply to smaller and more immature babies, and additional studies are necessary. We need to keep in mind that meta-analysis should be the starting point of evidence and not the last word of the process, especially when meta-analysis is done in interventions that are open. So in other words, the investigators or the research team doing the intervention know if the patient is under A or B therapy, because that introduces bias. It's inevitable. So if you look for this meta-analysis, intubation and mechanical ventilation in babies exposed to NIPPV was 16%, compared to 20% on CPAP, and for babies that did not get surfactant. And in total, if you put all together with the surfactant administration, minimal invasive or mixed, you will see the intubation and mechanical ventilation occurred in 15% of the babies exposed to NIPPV and 22% of the babies exposed to CPAP. Well, no, we decided to look, because this population has a gestational age around 30 weeks in the Cochrane, what happened with our patients born between 29 and 31 weeks. And our intubation failure rate is 8.7%, not 22 or 15, as reported here. So every time you see some interesting results and interesting investigations, you need to know how that translates to your center. So they have a much higher failure rate on their studies. Now, if you go back to the Cochrane review, you see one of the studies that was included here was the larger trial. And the PI, and that's the problem of bias, of that larger trial, published a letter in November 2007 in JPEDS saying that our unit has been using NIPPV for initial respiratory support in preterm infants with RGS. As part of an ongoing study, we are finding that it does reduce the need for mechanical ventilation compared to CPAP. That letter was published in November. The trial, which was a single-center trial, has initiated in August. So by the time the trial was initiated and the author wrote the letter and the letter got published, the letter was submitted at the very start of the trial. And clearly, they already knew that NIPPV was better than CPAP. And if you look for the numbers of that trial, 25% of babies on NIPPV fail compared to 34% on CPAP. And if you look for the all studies together, it's 11 and 13 if you remove that trial. So basically, there was a big influence of this trial that has a huge bias on changing the difference between one and the other one. Other problems is that in the Cochrane meta-analysis, 17 studies were included and only 8 evaluated extubation failure. So you basically, the Cochrane, when we report on that, is reporting a subgroup analysis. Of these 8 studies, 7 were single-center experience with small sample sizes. And 71% of all included infants came from one, the Canadian multi-center study. And in that study, there was no difference. And the studies included had many different definitions of failure. And if you look at the definitions of failure, they go from reintubation at any point or not reported, or 48 hours, or 7 days. So for the reintubation, the application of CPAP and NIPPV, it's pretty unclear that NIPPV is better. Because if you use the definition of 7 days, the failure rate is absolutely the same. What about using NIPPV with synchronization? There's a small study from Italy that showed that the number of desaturations and or bradycardia or severe desaturations in babies having apnea of prematurity was significantly lower when the NIPPV was synchronized compared to non-synchronized NIPPV or compared to CPAP. We did some study on NIV-NAVA, which is a synchronized mode of non-invasive ventilation, compared to NIPPV not synchronized and CPAP. And the synchronization, as you can see here, when you use NIV-NAVA, was perfect. Basically, every single breath of the baby is assisted by the ventilator. The problem is that NIV-NAVA has a proportionality issue, and when babies have apnea and come back from an apnea, they have small breaths. And the way the machine understands, if the breath is small, it doesn't need help. So there's only, as far as I was able to find, one randomized controlled trial from China on NIV-NAVA versus CPAP for extubation or to prevent reintubation of these babies. And you can see that extubation failure in the first 72 hours or reintubation in the first 72 hours was more than 3 times higher in the CPAP compared to NIV-NAVA in their study. And if you look at 7 days after extubation, it was higher, but now not significant because the N is small. Some people have been using nasal high-frequency oscillatory ventilation. It's another mode because it does not require synchronization, and bench studies showed that it effectively eliminates CO2, and some animal data say it promotes less lung inflammation. So there's a meta-analysis of randomized control trials, not too many, evaluating non-invasive high-frequency ventilation as a mode of respiratory support to prevent intubation. And only 2 of those trials evaluated small babies. And if you put them together, in the first one, only 13 patients were randomized to one group and 13 to another, and there's basically no intubation in none of them. And in the second study in 2017, this number is 16 and 23, and the failure rate with high frequency, nasal high frequency, was 37% compared to 65 on the bubble CPAP. It seemed not bubble on the CPAP, and seems that it was pretty high failure rate. There was recently a randomized control trial from China, the NAZON study group, that extubated patients to CPAP or NIPPV or nasal high-frequency oscillation, and majority of the patients were above 28 weeks. And the reason why I'm highlighting that is that extubation failure rate in babies that are above 28 weeks is very unusual. So the majority of babies in their trial was that. In the APEX study, which was a Canadian-led study by my group, you can see that no patient extubated with a gestational age 28 weeks and 3 days over that failed. And only 1 patient at 28 weeks failed. So basically, there's no extubation failure when the patient was above 28 weeks. But in that trial, the failure rates were 25% in the CPAP group, 17 in the NIPPV, and 13 in the high-frequency oscillation. So the nasal high-frequency oscillation was half of the CPAP and similar to the NIPPV. However, there were no differences in any of the outcomes that they looked here, such as bronchopulmonary dysplasia, moderate to severe, use of steroids, in-hospital mortality, or BPD mortality. So even if you are not convinced that there's no good science showing that NIPPV is better than CPAP, and you want to use NIPPV, there's still a number of questions unanswered. So what kind of ventilator you're going to use? Because the studies use several different ventilators, including BiPAP machines. Are you using synchronized or not synchronized? Both modes have been put together in the studies, and we're still waiting for a good study, a large randomized control trial with synchronized NIPPV. If we're going to use nasal high frequency, how? What settings? If we're going to use NIPPV, what PIP levels? 10, 25, it's very variable if you look at the studies. Also, PEEP levels are very variable, rates are very variable, I times and interfaces. Basically, you will have to choose one of each of these parameters and decide what to do in your unit. And what I can see that in many units using NIPPV, there's a large variability on those settings decided by the physicians. So given that, at the Montreal Children's, we decided to adopt a protocol for the use of bubble CPAP therapy in our unit. And this protocol has been published, and the main purpose of the protocol was to harmonize the routine care of patients on CPAP therapy by assuring proper indication, installation, and maintenance of the interface and the system for the weaning and discontinuation. So in very short terms, what the protocol says, it's a very comprehensive protocol. I just tried to summarize here. We initiate bubble CPAP in the delivery room immediately after birth in any baby that's less than 32 weeks and is spontaneously breathing, but you can also put in any newborn that has respiratory distress. We always use the interface, which is short binasal curved prongs. So it's one type of interface all the time. We tolerate FiO2 less than equal 50 on CPAP before we say this is a failure and we need to intubate. And when the babies remain on CPAP, we keep them on CPAP until they are asymptomatic. So they have no respiratory changes, and they are on room air, no oxygen needs, and they are matured enough. So we have extended CPAP therapy because it does have some evidence that by doing that, you promote lung growth on these patients. So what happened after the implementation of this protocol? This is the 2 years before the protocol, and then the first and second year. So every period here, it's a 2 years period. So 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. And what you can see here is that the use of CPAP in the delivery room for babies less than 1250, it was only 35% before we adopted the protocol. And this went up to 59, 68, and 75. So here, 2019 to 2020 in Montreal, if babies are born, for babies born below 1250, 75% were not intubated in the delivery room. They left the delivery room on CPAP. And during the first week of life, 0 to 168 hours, the proportion of infants that remained on CPAP, this is before the first 2 years, and then as we gain experience, we got better and better. So it's a high proportion of babies that are not intubated in the delivery room and are not intubated in the first week of life. And that has translated in a significant drop on death from 10 to 5% with a P of 0.01, a drop on death, combined death, severe BPG from 21% to 11 with a P of 0.02, an increase in survival with no or very mild BPG from 68 to 80%. So 80% of babies less than 1250 on 2019, 2020 left the unit with no mild BPG. As I mentioned, delivery room intubation decreased to 25%, 24%. NICU intubation remained the same. Therefore, the combined went down from 81% to 60%. And if you compare our results in 350 babies, and you use the definition, the 2020 Jensen definition, if you look at death or severe BPG, our numbers are 8% compared to many networks in the US with large population publications. They go from 14 to 19%. So we're pretty much half of that. So I hope you have appreciated that, no, we don't really need to intubate everybody, and it's very important to have a very meticulous, detailed approach to be successful. Thank you. I'm very happy to take any questions. You are mute.
Of course, I've been doing this for 4 years. Of course, I'm still mute. I haven't learned my lesson, but thank you so much for your presentation. Those numbers are incredible. Congratulations. This is really, really amazing work. Is this the standard now in your hospital? Is this what we're trying to spread across Canada right now?
I hope so. We have presented, Mark Beltempo has presented data to the CNN, and we had a few centers coming to visit us. And yes, it became the standard of care in 2014 and it's still the standard of care. If you go to our unit, you will see that 20, 25 babies are on bubble CPAP at any day. So it's a very large number. And the more you do something, the better you become. So if you keep practicing the same thing in the same way for a long time, chances are that your success rate is going to go up. So it was thankfully, it was a one-way road. We adopted that. We saw the improvement. Initially, we just saw the improvement ourselves, and then we decided to pull the numbers, and then the numbers confirmed what we're doing. So right now, when our team goes to the delivery of a 23, 24, 25, 26 weeker, they feel sad when they have to intubate. So they do maximum effort to keep them on CPAP, as well as when they have to intubate in the NICU, they don't like it. So it became a very non-invasive ventilation unit. But, for success of the therapy, I am convinced that you need to have a protocolized way to do that, and it is a team effort. Now, it has to be, everybody needs to be on board, including the parents, to understand and help us. What is the goal of that? Why you're not intubating right away? And then you need to explain everyone, the nurses, respiratory therapists, the parents, what is the goal here? And then show this data that I show you. If you can avoid, if you cannot avoid, end up intubated, even if you have delayed, that's no harm to wait 6, 10, 12 hours. And then some babies are intubated after 12 hours. And then we sometimes get this question, should you have done that before? The evidence is that there's no harm of waiting. So it's a team effort. And yes, it is our standard of care now.
Amazing. So I think can we unpack a little bit of that what you just said, because a lot for parents to take in. I'm sure there's many parents on listening to us today. How do you assess the baby readiness for not being intubated right away? That's let's start unpacking right there.
We have a protocol for that because we do not want to be done in different ways depending who is there. Mm-hmm. So we have specific criteria in our unit. First, we don't count much the first 2 hours of life, because as soon as you are born is a transitional phase. There's a lot of stress for the baby, a lot of handling and moving from the delivery room to the NICU and putting catheters and doing checking. So, and then of course, baby gets stressed, the oxygen needs goes up, and he's breathing very stressful. So when we finish all that, we let a baby alone for the next hours. And then we have 5 specific criteria that we define. This is a failure. He's going to need to be intubated. One is the oxygen needs more than 50%, consistently going up and needing more and more and more oxygen for a few hours. Then we say, well, it's time to intubate and give surfactant and put in mechanical ventilation. The second, and this is the number one reason, 85% of the cases are intubated because of that, because FiO2 is going up. There's few babies are intubated because of apnea, they stop breathing, and then you had to really do a stimulation, and then they stop breathing again, so this is it. It needs to be intubated. Or if you start having not significant apneas, but multiple, so you have one and then have another one and then have another one, they're not too bad, but their number goes up. It's another criteria. Or if you have a significant respiratory acidosis, basically your CO2 go up, and then you become acidotic. But usually when that happens, the FiO2 goes up at the same time. In fact, the FiO2 goes up first. So the majority. So those are the criteria that you need to tell everybody in the unit that everybody does in the same way. And I think this was a great advantage of the protocol, which was to harmonize the approach.
Absolutely. So you mentioned 23 plus. is your center resuscitating the 22-weekers, or you're not there yet? And if you are there, what is the protocol for the 22-weekers?
Yeah, it's the same. We got a 22-weeker that we put on CPAP in the delivery room, and that baby a few hours later failed and got intubated. So it's not that I believe a 22-weeker can make it without an intubation. The vast majority, 99, 100% of babies between 23, 24 end up getting intubated. The thing that we prefer to do the intubation in the NICU. It's a much more controlled environment. So we stabilize that. You can stabilize these babies with CPAP in the delivery room. Majority of them, you can stabilize. So we stabilize the baby with CPAP in the delivery room, and then go to the unit, and then you can do the intubation 2, 3, 4 hours later in a much more controlled environment. So yes, we do we have had 2 babies, 22 weeks, and we approach in the same way.
A question for you in regards the long-term outcomes. You mentioned the babies, you have a drop on the death rates of severe BPD, or even mild BPD, going home with no BPD. So for the parents listening to us, because it feels like there is this quest on this non-invasive ventilation across so many options, why this matters for families? Like, because we always talk about what is the long-term outcome of having a baby with severe BPD. This is going to be a life condition. I just want you to talk to parents a little bit more, and also your colleagues listening to us. How do you really counsel parents or explain to parents what is happening if the baby gets a mechanical ventilation versus non-invasive ventilation? Because when you come to the ICU, we know nothing about anything. The fact that the baby, we hear that our baby is ventilated, it seems so scary to us parents. And then you talk about, okay, this tiny baby, 23, 24 weekers, now is on CPAP, which is something that many people heard about, but it might fail the CPAP. And what is the consequence that we're trying to avoid by not having this mechanical ventilation, but have this less invasive for the baby's health on the long term? And how do we counsel families?
Yeah, this is a great question. And I'll try to answer this question on the best of my ability. So I usually talk to nurses and to anybody that's around and say, if you can spend 10 days in the ICU as an adult, would you prefer to spend 10 days intubated, mechanically ventilated, or 7? Most people say, well, if I can have some days that I'm off the ventilator, even though if it's a CPAP, I would prefer that, you know. So those machines, they keep you alive, but they damage you. They damage the lungs. As soon as you put an endotracheal tube and you deliver positive pressure, it's the opposite of what we do. We breathe with negative pressure, not positive pressure. We don't have plastic into the trachea. So we don't have oxygen concentration more than 21%, which is room air. So everything that you are doing when you intubate a patient, it's non-physiological, and it's just to keep them alive and damage them. Well, the lungs are very big. Every single blood in the body goes to the lungs to get oxygenated, to eliminate CO2, and then circulate. So basically, if your lungs are damaged, if you have inflammation going on in the lungs, you're going to have systemic inflammation. Systemic inflammation is clearly associated with brain issues, developmental issues. Also, by having a mechanical ventilation in a patient, increases the chances of infection, because you have to suction, you have to have secretions going, increases the chances of aspiration when the babies are feeding, because your airway is open. So in our study, and I didn't have time to show, one thing that was very interesting is that our infection rate went down significantly with the introduction of the bubble CPAP protocol. And that was not associated with the fact that we have done any bundle to decrease infection. It's just, I believe, because many less babies are intubated and mechanically ventilated. So if you decrease infection, sepsis is associated with their developmental problems. We know that lung injury early in life, even if you don't want to call it BPG, doesn't matter how you call it, lung injury early in life changes the lungs structure, changes development. And lungs of any baby born today, they have to develop in the next 8 years. So you don't have the lungs for your life as you were born. Those lungs will go through a developmental phase from birth to 8 years of age. And then you become an adult with a developed lung. There's enough evidence showing that by exposing them to mechanical ventilation, you change the trajectory of lung growth and development. Whether you call that BPG or not, you may pay a price when you are 40, 50, 60 years of age, that your lung function start to go down as you age, but your start point is already down because you have been a preemie intubated. So there are many implications. I never talk to parents about the name BPG. I talk to parents about what I'm saying to you here, about lung injury, lung function, lung development, which is associated with mechanical ventilation of no doubt. So if you have a patient that has never been intubated, has always been on CPAP, that patient is certainly not a BPG, or whatever you want to call that. Personally, the baby lung certainly is better with less injury than the lungs of babies that have been mechanically ventilated for days.
Wow.
I don't know if that answers your question.
No, but I tell you, this was the best explanation for me to hear as a parent what it means to mechanical ventilation, what it means for my son to be diagnosed with BPG, because yes, BPG for me doesn't mean anything. But when I came home, my son was ventilated for 7 weeks, okay, or mechanical ventilation. And I joke that he tried every machine in the house because he went through all the different kinds of ventilators at that time. He did come home on oxygen for a year. Okay, I heard about 12 years ago, oh, your son has chronic lung disease, which I was crying because, oh, is this chronic for life, right? What does that mean? I didn't know what it meant to us. I didn't know that could impact his development. He does have a cerebral palsy. He was diagnosed at the age of 20 months. And we had several readmissions on the first 4 years of life for respiratory infections. So I think what you just said now is really important because it's the function of the lung rather than, I go to conference and everybody's talking about the definition of BPD. It's like, okay, what does it mean to us families? What does it mean to my child? Not only the short term, but on the long-term outcome. We see adults who are born preterm who are now in their 40s, and they talk about the struggles that they have with breathing. Now, I know in Holland, in the Netherlands, they have a BPD clinic for adults born preterm. So I think it's incredible to look at what ventilation really does and how to counsel and talk to parents about it, because yes, it matters. And I think we all should be striving to less invasive ventilation when possible. But my question to you is, when it's not possible and you still have to intubate the baby, what is the effort to have this baby out of the vent as soon as possible? And how do you determine that? Because I always listen to you talking today. Okay, Gabriel failed so many times extubation. He has to be intubated several times during those 7 weeks.
Yeah. Another good point, I like to say, not just me, but a lot of people that work in the same line, trying to avoid by having protocolized CPAP and, specific type of CPAP, like I presented now. I like to say that, it's not the end of the game end of the world if you fail. Some babies are born with much more significant lung disease, and CPAP cannot do miracle. Now, if you really have very immature lung with a huge surfactant deficiency, well, it's going to need to be intubated and get surfactant. Otherwise, it's going to die. So I think, when you fail, the next step is to have a very nice protocolized approach on how to be gentle as much as possible on the mechanical ventilation and remove it as soon as possible. So there is no one rule applies to all, because I think care has to be individualized. Every patient is different. So if you try to say, well, let's use ventilation in this way, you're going to get babies better. And that's true for maybe 70, 80%, but there's always a 10, 20% that no matter what you do, they do different. So I think as a general principle, it should be have criteria for failure. If he fails, intubate, give surfactant, initiate mechanical ventilation. Please have a way to do mechanical ventilation very gently and wean and remove as soon as possible. And if you follow all these pretty much in the same way, everybody, you'll be successful in 70, 80% of the cases. And you still have like a 10, 20% that will get extubated and fail and go back and fail. And extubation failure, which has been the subject of research that I've done for the last 15 years, I know it's complex. There's a multiple reasons why babies can fail extubation and need to go back into ventilator. And this is a matter of hours and hours of discussion here. Mm-hmm. But as a general rule of thumb, extreme preterm babies have a 15 to 25% failure rate, no matter where you are and what you were doing. And in some centers it's higher because people are more aggressive in extubation. And some centers is lower because people are more conservative in deciding to extubate. So, and if baby fails an extubation, it for sure, it puts him back on the mechanical ventilation, where I just told you the mechanical ventilation is not good. So every time you fail, and so I'm not surprised your son had to go home on oxygen with multiple extubation failures. So which one, it's a combination. It's the disease or the problem that made him go back into the ventilator, or the reintubation itself that created all this problem. It's probably a combination of both. Could I have predicted before extubation and therefore let him on ventilation longer? Everybody's still doing research on that, on good predictor of extubation failure. We do not have the final tool. We have some tools that gives you, again, 70, 80% chances of being right, but also a 20, sometimes 10% chances of being wrong.
Right. Wow. Just listening to you brought me so many memories from my time in the NICU, and for those days when, okay, let's extubate him today, and a few hours later, let's intubate him again. Yeah. It's like, and I tell you, the PTSD on parents is real. Yeah. And 12 years later, when I hear those things, I still have a hard time, taking in that information and look at, at the outcomes of all those days from the NICU. So it is not easy to, recently, we know everything's going to advance all the time, but sometimes it's hard for parents like me that do this work and say, what if it was now, right? But we can live that way, but it gives us so much hope for the future that we are doing something in a better way and moving towards better ways of doing care for these babies.
Yeah, it's just, I think, the way you phrase things that are very important for parents when you are in the NICU, leading the care of a patient. I've been in a meeting recently, and I heard people saying, oh, parents don't care about diagnosis of BPG, but they do care about extubation failure, like you just said, right? Well, they go together. Mm-hmm. They're pretty much, comorbidities, so if you get extubated and don't fail and don't get reintubated, you're likely not going to be a BPG. But if you get 3 reintubations or 3 extubation failures, then you're more likely to injure the lungs or airway. So they go together. It's just the way you phrase to parents what is the problem, what is the advantages, disadvantages, and the issues here.
Absolutely. And what that means. So I just want to switch gears a little bit because I'm from Brazil, just like you are, fellow Brazilians. And I'm always in awe of the work that you do because you came to Canada, you established an incredible career here in Canada doing all this amazing work, but you still go back to Brazil to teach what you know, to share your expertise, your experience. And I feel so incredibly grateful that you do that on behalf of families. And I just wanted you to talk a little bit about what you teach now. Is this as important in low-income setting countries? Because, we're in Canada, we are a very privileged country. You have a public healthcare system. We have somewhat a standardized care for our neonates. In countries like Brazil, and you still go back there to teach, to give back to Brazil, is the work that you're doing here just as important, I think, in those low-income setting places, not only Brazil, but the whole Latin America, Africa, other places where we don't have the same privilege that we have here in North America?
Yeah, no, absolutely. And babies are babies anywhere you go. And if they're born in South America or Africa, you are concerned because you want to protect them, you want to help them. So when we do teaching here, perhaps the impact is less because you're already going from a high level of care. Your baseline is high. When you do teaching there, the most important thing by doing teaching there is knowledge translation. So in many centers in South America, especially in Brazil, that I go back to Brazil 3-4 times a year for teaching, like free teaching, and sometimes, even pay myself to go and teach them. You're basically taking knowledge to them. And it's basically really teaching them what's simple things that they can do. They don't need to be in Canada with the highest level of technology, but they have technology that has not been used to the full potential of the technology. And they have organizational issues that you can help them to organize themselves. So it's basically know-how. So knowledge translation, I walk, every time I do teaching there, I go to the NICUs there. So you walk into the NICU and see the way they're practicing, and then you come up with suggestions. Oh, maybe you can do that here and do that. No suggestion, oh, maybe you can buy an ECMO machine. No, we don't do that. We use simple tools, and been doing that for since 2016, more officially. So it's going to be 9 years next year. And since I initiated that, I think it has helped a lot of places there. We created websites with the Ministry of Health. We created many workshops. So my feeling, I don't have the numbers, but my feeling is that many centers got better. There was a huge stimuli for people to learn because I go there and I speak in Portuguese. So this is a Brazilian who is working outside and is taking his time to come here and help us. People are very grateful, and 100% of the time I've been super well treated and very open. They open the doors of the NICU for me to come in and see. So it's a different feeling, when you do research here and help here and there, but both are very rewarding.
Wonderful. And we do have a comment here from Beatriz. I can tell his work is important here in Brazil and help change the mentality here. We're thankful for that. So thank you, Beatriz, for sharing that. And I could actually see that when I met you in Brazil last year, how everybody came to talk to you and ask questions is really incredible. And I applaud you for doing this work. And a lot of time, as you know, is on your spare time that you don't have to take the time
Yeah.
to go and build capacity in other places. So it is feasible. But before you wrap up, we are already at 2 o'clock here Eastern time. I want you to briefly talk about this amazing project that you're working on that I learned about it last year. And we're going to come back in 2025 for Premature to talk about the Smart Hospital project. So tell our audience, what is that all about? Where we are at? Where are you moving towards?
Thank you. And thank you for being here in September when we presented that. I know you're also very busy and took your time to come here. So it was very appreciated by myself and everybody here. It's basically a project to couple new technology and family needs. So we want to bring to the table new ways to monitor vital signs, new ways to show parents information about their babies. So basically, use technology to make the life into the NICU simpler, more friendly, less stressful to parents. And at the same time, there's another line that's developing new technologies that are going to capture vital signs that we don't capture now, such as sound. And sound can be breathing sound or bowel sound or cry of the baby, capturing movements, position. So things that we don't monitor right now, we just observe or very briefly in a snapshot, listen to the air entry. We want to capture that continuously, non-invasively. Part of the project is to eliminate the wires and cables and make the environment looks nicer, and the baby is more mobile, and it's easier for parents to hold and their baby and stay with the baby, less stress. And there's some other aspects. The project has initiated during the COVID, so it was very difficult in the first 2 years because it was 2020 to 2022 was difficult. But it's really progressing well since then. We have made a lot of steps forward, but it's a long road. I hope we can start to have some implementation in the next year or two, because we are now in the third generation of the wireless sensors. We keep testing them and making them better. And first generation of a parent's dashboard. There's many other things. Whoever wants to see more and learn more, you can just go on the website. We try to keep the website updated. I'm very excited with that. So we are talking to the foundation for the next 5-year cycle. Hopefully, they're gonna find support for that.
That's incredible. Dr. Sant'Anna, thank you so much for being with us today, for sharing your careers, really work, your knowledge, your expertise with our audience, with our parents today. And I'm so grateful that you took the time to wrap up 2024 Preemie Chats with us this year.
Thank you. It was a pleasure. Thanks again for the invitation. Nice to see you again.
And to all of you joining us live today, thank you so much for being here in this special session. It is our session 349. We started these sessions in 2020, right at the beginning of the pandemic. And I also want to thank our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder that if you miss part of today's session, head over to our website, which is, I'm going to share the link here, the canadianpreemies.org, and you can see this episode of the Preemie Chats and all past editions of the Preemie Chat series. You also find many resources and support options available there, and you also be reminded that CPBF is a charitable organization and depends on support to continue its important work. So consider how you can support CPBF and its mission to empower families of premature babies every step of the way. And we'll be back on January 17th with our Preemie Chat. We're going to take a short break during the holidays. So stay with us, because together we believe that we can create a brighter future for all preemies and their families. and we'll see you in 2025. Stay well.